So 79-year-old female, healthy, has pain around a failing number 22. I'm not sure if it's an implant or not. She had 3 implants placed 15 plus years ago, supported her mandibular overdenture, so probably an implant is failing. However, 5 years ago, the implant in 27 avulsed, meaning it failed. And eventually 22 implant became symptomatic, which is the one currently. Attached screenshot from CBCT prior to removal. Patient would like a stable denture. Should I remove the 24 implant and can place 2 implants? See attached screenshot. My concern is amount of resorption in the posterior mandible, mandibular fracture. Yes, mandibles can break if you're not careful. Thank you in advance. Correct me if I'm wrong here. So I'm seeing obviously the mandible. This is our mandible here. We can see an implant in one location. We can see another implant in here. And can we add more implants? So this is the suggested implant. So yeah, I mean, what else are we going to do? I feel like let's not try to remove implants that did not fail. The one that is symptomatic needs to be removed, but let's find more positions in the jaw to help support. And yeah, the mandible is very atrophic. So try not to do bicortical stabilization. That's how implants used to be in the 70s and the 80s. Stick them in the top cortex and exit through the lower cortex. That was a certain approach back then to get bicortical stabilization. Today, with the liability and the way implant surfaces are, it's not just mechanical anchorage. The implants are rough. They have micro and macro threads, so the bone grabs much better. You don't need to stabilize them, in my opinion, that deep. Second question is if you have enough bone to support. But I feel like that's what we need to do. We need to add implants. That's the key.
Yeah, that's key. If the doctor can move the implant on the left, maybe a little more distal to get more anterior posterior spread, that would be good if there is bone. And I like what you're saying.
With overdenture, the discussion on an AP spread, there's not enough AP spread. That's what they're going with an overdenture. So the AP spread is going to be very little.
Yeah.
So it applies more for fixed restoration. So from what's going to happen with an overdenture, it still moves. It's not rock solid, right?
Yeah.
So if this baby is gone, if this baby is out, if you can find another spot here and here, that's great. But just be aware. I mean, you don't have much to work with. You just have, that's it. You have probably a knife edge ridge. You need to reduce it and try not to go through the other cortex.
And the cases that I've done like that, one of them especially, even though I was far away from the mental nerve, something happens to the nerves there, and the patient was feeling it. So just be aware, be very, very clear on your anatomy. And if you can possibly use a guide, it will alleviate a lot of the guesswork and the stress during the surgery, just because it's a tough case.
Got it.